Lucknow. Ladies and gentlemen, our first presentation would be on evolving antithrombotic strategies in chronic atherosclerotic cardiovascular disease. Dr. Rajeev Agarwal, Chairman from the Department of Cardiology at Jaswant Specialty Hospitals, Meerut, would be in action for the next 12 minutes. Dr. Agarwal, please.
Good afternoon, ladies and gentlemen. It's a pleasure to be in Lucknow and meeting friends and accomplished clinicians, academicians. It's a great opportunity not only to pass on what you know, but to learn from each one of you. I'm being told by the organizers that we have absentee. One speaker is missing, so maybe we have a luxury of a couple of minutes.
No, my sincere apologies for the interruption, but we have been asked to continue with the scheduled time. Thank you.
Okay. So I am going to talk about evolving antithrombotic strategy in chronic atherosclerotic coronary artery disease. And this is the essence of the whole concept of atherosclerosis. And when you go home, keep remembering atherosclerosis never sleeps. It may be not noisy, but it never sleeps. And when we look at atherosclerosis post-acute coronary syndrome or otherwise, there are multiple approaches which give us dividend in reducing the risk in times to come. We had been very focused on lipidology, LDL, lower is better. Some may say, European guidelines may say 40, Lipid Association may say 30, American guideline continues to be on 55. But the bottom line is it's a bottomless pit, lower is better, and if you achieve lower, don't try to down titrate the therapy because lower is always better. Fourier has shown that there is a gradient of event reduction beyond 10 milligram of LDL. So even if you are 10 milligram, you are fine provided there is no problem. I'm not saying it's a guideline, but this is the outcome of Fourier data. Then we have inflammatory risk which has to be reduced. Unfortunately, the concept is very strong, but we are not having good clinical molecules. Colchicine is coming up, but still class 2B. Then we have residual thrombotic risk, which is being imparted by platelet activation as well as thrombin activation, which is a reality over a period of time when you follow these patients long term. TG risk is there. Everybody knows about TG, that this is one of the players in atherosclerosis, but let me say till today, there is no therapy which suggests that reducing TG reduces the risk till the prominent trial comes. LPA is again a risk factor, but we don't have drugs to treat LPA. And then we have newer drugs like SGLT2 inhibitor and GLP-1 agonist, which can reduce atherosclerosis and may improve the outcome. So my focus will be on residual thrombotic risk, largely imparted by thrombin activation. Like we say, there is nothing like a stable heart failure. Similarly, there is nothing like a stable coronary artery disease. If you have diabetes, polyvascular disease, these patients continue to show or throw events in long-term follow-up. Another thing is, we had been living with primary and secondary prevention, but secondary prevention is not a homogeneous group. There are multiple groups and some risks are very, very high risk, and you can understand with this slide. So when we look at these high-risk patients, the platelets play a role in acute events, but when we follow up them, these patients on chronic coronary syndrome, thrombin also plays a very important role, and that is why the concept of dual pathway inhibition came, that we reduce the platelet aggregation as well as we reduce the thrombin component of atherothrombosis. So this is how we look at the two pathways instead of focusing on just antiplatelets. You have to profile the patient, more the risk factors, more is the event, more are the event, it looks very logical. If you have 3 risk factors, the event rate is 2.9. If you have 3.5, so there is a linear relationship, and when you see your patient in clinic, always remember how many risk factors are there. This is a REACH registry, showed another very important thing, that if you have one vascular bad involvement, risk is minimum. If you have 2 vascular bad involvement, risk is more. If you have 3, the risk is more. And what I mean by vascular bad is that if you have coronary artery disease with peripheral arterial disease, coronary artery disease with carotid artery disease, or CVA, so look at these clusters of antithrombotic chronic syndromes. If they are existing in your patient, this patient is very high risk. And this is the way, diagrammatic way, we can see a risk continuum which is being studied in COMPASS trial. Before I talk about COMPASS, these are the 5 basic foundations of COMPASS. This is chronic coronary syndrome. I am not talking of acute coronary syndrome, so don't treat your patients of acute MI with this trial. I am talking of normal sinus rhythm. I am not talking of AFib. The moment patient develops AFib, he goes out of COMPASS trial. I am talking of vascular dose, low dose versus AFib dose. They are 2 different things. I am talking of high-risk patient of chronic coronary syndrome, not low-risk patient, not every patient. Then I am talking about tertiary prevention, if I am allowed to speak, vis-a-vis secondary prevention, and it is an artificial classification because COMPASS enrolled patients mostly beyond 1.7 years or so. They were not immediate follow-up patients. So they were chronic coronary syndrome patients who are having long duration of chronic coronary artery disease. They are not just 1 year after. This was a trial 2.5 twice a day with 100 milligram aspirin, one arm. Another arm 5 milligram, no aspirin, and aspirin alone. And we use 75 milligram, but it is in this trial 100 milligram aspirin was used. 27,000 patients, just less than 2 years of follow-up. Even then the trial was positive, 23% females and 38% patients were diabetic. High bleeding risk patients were excluded, severe heart failure, hemorrhagic stroke, and recent stroke less than 1 month because of hemorrhagic transformation, they were excluded. Advanced kidney disease, advanced heart failure were excluded because probably the patient will die earlier and trial may not show the outcome advantage, so they were excluded. If you are insistent of dual antiplatelet therapy, then these patients were also excluded. The COMPASS trial was in 2017 highly significant, that rivaroxaban and aspirin, and rivaroxaban, once again I repeat, in 2.5 milligram twice a day. Once again I repeat, they are normal sinus rhythm patient. MACE was reduced by 20%, net benefit 20%, mortality reduction 18%, and these patients were best treated, 72% ASARB, 92% on lipids, lowering drug, and 75% received beta blocker. So these patients were very well treated patients, and despite that the trial was positive. And if you look at the primary MACE, all-cause death, CV death, and net clinical benefit, all the p-values were significant. So this was an altogether new understanding in long-term management of chronic coronary syndrome, in patients with normal sinus rhythm, in patients who are diabetic as well as non-diabetic. Patients who were less than 65 and more than 65, both were benefited. If you have polyvascular disease, on top you can see the crocodile-like mouth of the curves. The separation is wider. So higher the risk, more is the benefit. eGFR less than 60 on top, they are doing better. No diabetes, diabetes again doing better. And if you are not diabetic, p-values is still significant, but less than the non-diabetic, less than the diabetic patient. And I'll tell you that this is the only trial where the diabetic patients in comparison to non-diabetic patients have shown more advantage. Otherwise, most of the trial shows similar degree of risk reduction in diabetic and non-diabetic patient population. So that way, this trial is significant for diabetic population. Heart failure, again, mortality is high, and you do better, your patients do better if they have heart failure. This is REACH registry, and if applied, this is a famous article written by Dr. Sonia Anand from McMaster, Salim Yusuf Group. If you have 4 such enrichment criteria and you follow up these patients for 23 months, relative risk reduction is 19%. I do not know in cardiology any trial where you can in 23%, in 23 months you can have risk reduction almost 20%. I am not aware. So this is a wonderful trial, need to be applied to our clinical patients. Stroke outcome. In these patients, only 4% patients were ischemic risk patient, ischemic stroke patient, and that too after 1 month, there was 50% relative risk reduction of stroke. So when the trial came, people said this is a trial for neurologists. No, it is not a trial for neurologists because this was a not stroke population, just 4% of the population, but it showed that if you have high risk vascular disease, stroke reduction is enormous. So it is not a stroke trial. Then if you can see these strokes, ischemic strokes, they are reduced, hemorrhagic transformation is increased, but hemorrhage is not increased. PAD is another group which is very, very important, and people say PAD is not a peripheral issue, it's a central issue. The moment you see PAD in your patients, be alert, it's a very, very high risk patient. Do whatever best you can do. Use aggressive lipid lowering, maintain on dual antiplatelet or on compass. Do best because they are very high risk patient. And if there is PAD and carotid artery, again you can see MACE and MALE both are reduced. MALE is called as major adverse limb events. So MACE and MALE both are reduced. This is amputation outcome, again favorable with compass patient. This is Voyager PAD, which is an exclusive peripheral arterial disease patient. And again, a trial is showing the same outcome as in compass sub-study, and the events reduction starts within a month. That is another beauty. It starts very, very early. Then in diabetic, again, you can see the risk reduction is more. The top curve is separating more than the lower one. So diabetic patient having more risk, they do better also. So that is another good outcome. All-cause mortality is also reduced. If the heart failure is there, then risk reduction is more. Commander trial didn't show advantage because the patient was sicker and they had mortality higher because of background heart failure. It didn't work out in CABG. That is another thing, that post-CABG patients are not the candidate for compass. Bleeding outcomes are definitely there, major bleedings are there, but fatal bleedings are there. There is 70% increase in bleeding incidence, but mortality is not increased. This is a frequency of bleeding. As the patient progresses over a period of time, the bleeding stabilizes, and I'll show you that bleeding over a period of time it stabilizes, and the gains keeps on increasing, and the risk, the benefit ratio keeps on increasing. So if your patient has not bled in first year, he is unlikely to bleed over a period of time. This is how bleeding is more or less constant. So incremental benefit, sicker the patient, more the benefit, and compass is probably a sweet point between ischemic and bleeding risk. This is the latest score just published last year. This is how you can identify a patient population who is an ideal population for the compass trial. Here P is peripheral arterial disease, R is renal failure, S is not sex or stroke, it is smoking, and C is severe coronary artery disease. And you apply this CHATS2 PAC score, PARS score, then probably the risk categorization is better. And if we look this therapy over and above the comparison, you see this therapy scores over and above all the therapies we possess in secondary prevention. Unfortunately, they are not being utilized. Even beyond SGLT2 inhibitor and PCSK9. So COMPASS is comparable to SGLT2 inhibitor and PCSK9. It's a very, very powerful trial. So just a simple diagrammatic run through that if your patient is high risk, no bleeding or low bleeding risk, chronic coronary syndrome, he is a patient for COMPASS trial, And if he has had ischemic stroke, you more bias towards compass patient. If the patient is not high vascular disease, the atherosclerosis, I say confined to heart, then you go for DAPT instead of dual pathway inhibition. So this is a diagrammatic representation, coronary artery disease with anything, PAD alone or PAD with SCAD, or post-DAPT patient if they have diabetes, renal dysfunction. Again, these patients are compass patient. DAPT is good. Pegasus, I am not being given the time to balance Pegasus and compass, how we place these two drugs. But DAPT reduces events. It is immediate acute coronary syndrome. Compass is a later placement, is not an immediate ACS, and DAPT does not reduce mortality while DAPI reduces mortality. So that is one basic difference, that mortality reduction is not seen. This is just a guideline published last week for intervention cardiologists. These are published by SCI, ACC, NHA to emphasize that intervention cardiologists are missing these things, and they have advised that they should look into all these things rather than just intervention alone. If the risk is low, the level of indication goes from 2A to 2B, you can imagine, because the risk is low. So I'll say compass can only work if you carry compass to clinics. If you read here and forget it to carry to your clinics, you will never be able to give this advantage of knowledge to your patient. And this is my last slide. I always believe that we have to grow beyond artery cleaners. We have to become artery healers. Coronary artery disease is not a mechanical disease. It is a metabolic disease. It never sleeps. Never forget that your patients who are high risk, low bleeding risk, having atherosclerosis beyond heart are the candidate for DAPI or dual pathway inhibition. Thank you very much.
Thank you, Dr. Agarwal. I'm sorry for the interruption, Mr. Chairman. Yes, totally